From Microbe TV, this is TWiP, This Week in Parasitism, episode 255, recorded on March 14th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What you got on your tie, Daniel?
Well, it is a Friday. I got a purple spirochete.
Well, STD syphilis, right?
It is Syphilis Friday.
Wonderful. Also joining us from Glasgow, Scotland, Christina Nowla.
Good evening, everybody. And I'm glad I checked the time difference because you moved back and I haven't.
Yeah, that's right.
Or forward or whatever. Forward. You've moved forward.
We sprung forward.
Yeah, and I haven't. So
do you not do it at all in Scotland?
No, we do, but I think it's only next week or even the week after.
It doesn't make any sense to me. I don't like it. We have a guest today who's going to help us with this clinical case. She is a physician in Health First Medical Group, Michelle Labrunda. Welcome to TWiP.
Hello, and speaking to you from Melbourne, Florida. It's bright, sunny, and beautiful, and I'm looking forward to this episode.
Yeah, I can see the sun streaming in your window there. It's beautiful. If you like these programs, we would love to have your financial support. We don't do ads. We have no source of income except for your generosity. So go to microbe.tv/contribute. Okay, Daniel, we had a very long clinical description last time, right?
We did, actually. And I'll say, Dr. Labrunda, since this is your case, do you want to just read through? Do you have the show notes? Are you good there?
I've got the show notes.
Okay.
Yeah, I'd be happy to read through the case. So basically, we have a 26-year-old woman. She's got no past medical history, healthy her entire life. And she's from Atlanta, Georgia, just outside of Atlanta. She had just finished up a double bachelor's degree in education and international studies. And she was signing up for a volunteer program in Guinea. So she decided to go to Guinea. And in Guinea, she was going to be working in an educational program. So she arrived in Guinea in December 2023. When she got there, she went to her site where she was going to be promoting this educational program. And, I've got some details in the description of where she is, but to say she's not on the coast, she's more inland, away from the coastal areas, away from the tourist areas. She's in a remote area, basically. So she was very good about researching what she needed to take to try and make sure she stayed healthy while she was there. She started taking doxycycline for malaria prophylaxis and had not missed any doses. So she had been compliant with all of her medications. But even with this, after several months in October 2024, she started to have fever and cough. She went into the medical center as an outpatient. They did some labs, and she was going to follow up the next day, but she just kept feeling worse and worse. She didn't sleep well that night. She was febrile. Her temperature went up to 104. She had a U.S. style thermometer since she was from the U.S. and it was 104. So she went to the hospital because she was feeling so poorly, and they saw her in the ER. She was febrile, and they really weren't sure what was happening. When they first brought her in, they did some vital signs. They found a temperature of 97.9. Her blood pressure was okay. It was 105 over 70. They did check an oxygen saturation, which was 98%, and her pulse rate was 94. They did a physical exam and didn't really find anything unremarkable. They empirically just started her on Augmentin and Coartem and thought that they should have it covered. So at this point, we started to think, well, what could this be? I was working with the physicians a little bit indirectly. I was in the U.S. while they were overseas and just trying to get an idea of what was going on. So what do you think the differential would be, and what kind of additional testing would we like to do at this point?
Christina, any comments? I mean, initially I sort of think, you're thinking fever, you're in the tropics, you're thinking things like malaria, you're thinking, number of bacterial infections.
Sorry, I was lost in thought. I was wondering, I was thinking about a case. I was wondering, is it normal just to give treatment without really?
And unfortunately, I would say yes.
Okay. And is that wise? I mean, I'm not a clinician, Michelle, so.
Well, obviously this is a parasite podcast, so this has to be a parasite.
It depends on the clinical situation. We don't typically, just throw random antibiotics at people. We'd like to have an idea what we're treating. If there's an emergency situation, if somebody looks like they're at risk for declining or have a very significant, what looks like a bacterial infection, we would start antibiotics. But no, we wouldn't typically just start antimalarials and antibiotics at the same time without having a little bit more information.
All right. So next.
All right. So we finally got some of the lab results back. And this was the lab results that were done in the outpatient setting right before her coming into the emergency room. She had a white blood cell count of 14. Her hemoglobin was 13, hematocrit 40. Platelet count was 285. Her absolute neutrophil count was 8, and her absolute eosinophil count was 0.8, which is elevated. She had a normal BUN and creatinine. Her AST was normal, ALT was 44, and her GGT was 125. In the hospital, they decided to do a stool parasite screen, and it did come up positive for some sort of eggs. We're not sure what kind. They did a malaria screen that was negative. And because she was complaining of cough and respiratory symptoms, they did a chest x-ray, which was read as bilateral pulmonary infiltrates. She was given a medication in the hospital. We're not sure exactly what it was. And as soon as she got it, she vomited half hour later. So whatever they gave her was likely not effective because she vomited it out. And then they gave her another dose of that same medication approximately 5 hours after the first dose, and they let her go home. So she was discharged from the emergency room. She went back home and she initially felt okay, but then she had a very similar episode that evening. She again had fevers to 104, but something new happened. She also developed watery diarrhea and nausea. She didn't have any additional episodes of vomiting, but the nausea and the diarrhea persisted. So she went back to the hospital, was given ibuprofen, ceftriaxone, 1 gram IV Q12 hours, and was admitted to the hospital. She continued to have fevers, abdominal pain, and was kept in the hospital for approximately 5 days and repeated the pattern over and over. They would think she was getting a little bit better during the day when the fevers would go down, but at night she was always febrile. She continued to have abdominal discomfort, and they kept testing it for malaria. They did rapid tests, they did slide reviews, and the malaria tests were all negative. They did do blood cultures while she was in the hospital, and those were finalized negative. They didn't see anything on gram stain either. She continued to have mild elevation of the white blood cell count while she was in hospital, but nothing dramatic. There were no significant increases from the baseline. And she did have a mild elevation of AST and ALT throughout her hospitalization. So after approximately a week of feeling terrible and not getting better, she was transferred to a different hospital. They gave her a different medication, and within about 24 hours, her symptoms miraculously disappeared. She got a whole lot better quickly. So the question is, what is her diagnosis and what happened with the management here?
Okay, Daniel, can you take that first one?
All right. Colorado State University's Uncultured Microbe Society writes, greetings from Colorado. We hope everyone on TWiP is doing well. Here in Colorado, with it being the start of March, the weather is getting more pleasant. The trees are growing back their leaves. Just simply put, it's awesome. Now to discuss something that is also awesome, the episode 253 of TWiP. Regarding the case presented, our guess is schistosoma. To get an idea of what species, we would request more information on the location of the spine and the egg that was mentioned. We would also be curious if the patient had spent any time in river/lake water, which could have been the route of infection for the cercariae. We felt that the location of the patient, the abdominal pain, the elevated AST and ALT all fit for this parasite. We were stumped on the cause of the cough, which we now think, after doing some research, is from what is called Katayama syndrome, which can be an acute sign of schistosomiasis. For our treatment of the patient, we would prescribe praziquantel. In regards to management, the two medications mentioned of Augmentin and Coartem seem to be for bacterial infections and for malaria, both of which would not treat the schistosomiasis. We were also curious if they did a urine sample exam for any eggs. When they did the stool sample, did they use fecal sedimentation? Anyhow, thanks for an amazing episode and look forward to the next one. Sincerely, Colorado State University's Uncultured Microbe Society.
Christina.
I think I'll do the next two. Srinathan writes, trypanosomiasis in acute presentation. Short and to the point. Then James writes, hello, hola TWiPolitas. I am writing to you from a cold but clear and sunny Manchester, England, a local. Firstly, I was so sorry to hear of Dixon's passing. I am sure lots of people will be writing in with tributes. So I will try and keep it brief. Sorry, can you hear my dog bark?
Okay. Yeah, it's okay.
It's all good.
Sorry about that. The Dixon-Vincent dynamic in the early episodes was the reason I got hooked on this podcast and why I subsequently developed an interest in parasitology. The patient and seemingly all-knowing but never pretentious Dr. D. Pommier paired perfectly with the inquisitive and sometimes mischievous Dr. Racaniello. Listeners of early episodes will remember Vincent bemoaning that he had to be nice to Dixon or we are going to get mail. I think we all knew the teasing came from a place of friendship and respect, but it just reflects the audience's affection for him. It really felt like we were being taken on a journey with Dixon as the teacher and Vincent as our fellow student. As many have alluded to in their tributes, Dixon had a gift for storytelling, which is what made him such a great teacher. He's taught me that just because I finished my formal education doesn't mean I have to stop learning. His passion for all things interesting shone through and was infectious. He will be greatly missed by us all. I first wrote into TWiP with a case guess just a few episodes ago for the case at the end of episode 249, but my last-minute entry didn't quite make the cut. As I mentioned in the email, I'm a junior doctor in the UK, currently busy preparing to sit the second part of the Royal College of Physicians membership exams while applying for internal medicine training. I'm trying to do the case guesses without consulting the internet to test my knowledge and see what I've learned, but I'll keep it short as I've got to get back to studying. Dr. Griffin's cryptic description of lack of eosinophilic clearing is a little perplexing, although I do recall a similar description in the case of a lady from the DR with disseminated strongyloidiasis. However, we currently have no reason to believe this young lady is immune compromised, and there is no evidence of a secondary bacteremia in the blood cultures. Hence, I take this to mean there is some different degree of blood eosinophilia present. Nonetheless, blood eosinophilia and ova in the stool in West Africa means we are dealing with some kind of helminth. The bilateral chest X-ray infiltrates would, therefore, likely be due to migration to the lungs, probably with associated pulmonary eosinophilia. Given that Dr. Griffin surreptitiously mentions nice places to swim in the local area, I would lean towards acute schistosomiasis, also known as Katayama fever. This would fit clinically with her acute febrile illness, pulmonary infiltrates, transaminitis, and I think schistosomal ova would be seen in the stool exam. Maybe the first hospital treated her incorrectly with albendazole or mebendazole, suspecting another helminth, and then she was treated with praziquantel after the correct ID and recovered. Looking forward to hearing the answer. James.
Michelle, do you want to take the next one?
Sure. I would be happy to. So this is
Hawken.
So greetings, TWiP team. Returning book winner here. Though this case sounded interesting and wanted to try and weigh in, before we get into it, however, I just wanted to briefly offer some insight into some of the trypanosomes discussed in the last episode. The horse STI trypanosoma of horses you were discussing is T. equiperidum. Yeah, I don't know my horse trypanosomes. not T. evans. While T. evansi is an incredibly interesting pathogen for multiple reasons, perhaps the most fascinating interaction it has is its ability to not only parasitize vampire bats, but also to use them as vectors to transmit back into other animals. Kind of neat. Whereas T. equiparidum is exclusive to horses and has no vector. This week's case seems like a case of schistosomiasis in our unfortunate traveler who was assumed to have malaria. Proper medication of praziquantel likely helped, and given the bitter taste, likely caused the vomiting. Thanks again, Hakon.
Kimona writes, Dear TWiP team, pardon the length, but you hinted at a differential. Hopefully I'm not too verbose. Malaria, despite diligent chemoprophylaxis, is always in the differential for a febrile illness in tropics, but less likely after repeatedly negative blood smears and treatment with coartem. Cryptosporidium hominis is found worldwide and can clinically vary from asymptomatic to profuse diarrhea with abdominal cramps. Its oocysts are found in stool, but it's often self-limiting in healthy people. Giardia lamblia is also seen worldwide, and cysts or trophozoites can be found in stool, but this presents mainly with diarrhea and steatorrhea and perhaps less fevers and acute illness. It is also often self-limiting or can be treated with a nitroimidazole drug. Entamoeba histolytica is a protozoan whose cysts and trophozoites are seen in stool and has an intestinal phase producing diarrhea, colicky, abdominal pain, and fever. If it spreads hematogenously, it can reach other tissues, most commonly forming abscesses in the liver and, by extension, pulmonary involvement. Perhaps this was the diagnosis at the first hospital, and her vomiting in the ER was triggered by a nitroimidazole. She would thereafter have been given an intraluminal agent like paromomycin to prevent continued spread. An ultrasound at that time may have shown liver abscesses, but E. histolytical is difficult to distinguish from E. dispar, non-pathogenic, on microscopy and could have served as a red herring in her original diagnosis. Tropical pulmonary eosinophilia can develop from many filarial infections and may cause marked eosinophilia and pulmonary findings on chest x-ray, but usually includes nocturnal wheezing, cough, and less likely to have abdominal and diarrheal symptoms unless a very high worm burden. My ultimate diagnosis settles on acute schistosomiasis, aka Katayama fever. Schistosoma mansoni, a trematode found in SSA, is easily acquired while swimming in local lakes. A snail is the intermediate host, releasing infectious cercariae that can penetrate host skin and eventually end up as mated adult pairs living in the mesenteric plexus for S. mansoni. Katayama fever is an acute illness seen mostly in people with high exposure levels or no previous immunity. It's a hypersensitivity reaction to migrating schistosomulae or egg production and presents with fever, cough, eosinophilia, diffuse patchy infiltrates on chest x-ray, and even abdominal symptoms. Gold standard for diagnosis, microscopy for ova and stool, but antibodies are often positive prior to this. PCR can also be used with the added benefit of schistosome speciation. Interestingly, adult schistosomes can harbor enteric bacteria like Salmonella and introduce these directly into the bloodstream. I entertained this as a possible co-infection, albeit not parasitic, but would have expected growth on her blood cultures and successful treatment by this ceftriaxone given during her first hospitalization. Praziquantel is the drug of choice for schistosomiasis, with oxyminiquin as an alternative. In an acute illness, a short course of corticosteroids may be given initially to prevent exacerbation of symptoms. Looking forward to the reveal. Warm regards from Vermont. Back to you, Daniel.
Paul writes, returning book winner, diagnosis acute schistosomiasis due to schistosoma mansoni, also known as Katayama fever. It occurs most often in new immigrants to an endemic region. Comment, pause to consider the differential and more history. The differential diagnosis of someone presenting with fever and cough is quite long and would include common bacterial infections, viral infections, TB, some parasites, and allergic hypersensitivity reactions. More history would include asking about exposures to ill people, exposure to water activities, animals. The mildly elevated eosinophil count was slightly abnormal liver tests and eggs in the stool specimen considerably raises the likelihood of parasitic disease. The providers appear to have anchored on bacterial disease as the cause and continued antibacterial treatment without widening the differential to include parasitic diseases in spite of having some lab findings supporting a parasitic cause. The effective treatment was praziquantel. Additional comment, having a negative malaria smear would seem to contradict treating immediately with coartem, although this drug has a role in prophylaxis and co-treatment with praziquantel for schistosomiasis. Paul.
Christina. Rafid writes, Dear fellow TWiP team, please accept my condolences for the death of your dear friend and colleague Dixon Despommier. He may be gone physically, but he lives on in my heart and mind. I can hear his voice right now in my mind's eye. Even though I did not know him personally and never met him, I will miss him. I am very saddened that he is gone. May I suggest that everyone listening to this episode take a moment from their day and listen to Lacrimosa from Mozart's Requiem to his memory. Back to the case. Although many parasites can be differential and cause digestive, hepatic, and pulmonary abnormalities, I think the most likely answer is Schistosoma mansoni. Cheers, a returning champion, Rafid.
Michelle.
All right. John writes, seeking to win the book. And I found this case challenging. However, I want to improve my brevity, hopefully without sacrificing the details on my thought process. To narrow down the field, I looked at what may be endemic in the region, what OMP tests can detect, and the symptoms list, like the absence of anemia and dry, non-productive cough. According to the Cleveland Clinic, Ascaris lumbricoides can infect lungs and intestines with cough, fever, abdominal pain, nausea, vomiting, diarrhea, and trouble sleeping. There were many other parasites that had many of these symptoms, and the lack of improvement from initial treatment may be due to overlap and more than one infection. I did rule out Giardia, Cryptosporidium, Strongyloides, Schistosomiasis, and Amoebiasis, but I was shaky on the Strongyloides with only anemia not lining up there. Treatments for Ascaris often improve fast with albendazole or ivermectin and would not have been taken care of by the previous medications attempted, so this matches the outcome described. Thanks as always. Love the show. Cheers.
I don't know what he's guessing. He didn't end up saying anything, right?
Yeah, I don't know. I think we got kind of a broad differential. But
okay. Michelle and Alexander from the First Vienna Parasitology Passion Club, right? Dear TWiP professors, we are deeply saddened by the passing of your friend and colleague, Dixon, whose work as an educator, raconteur, and scientist has had a profound impact on the trajectory of our medical interests. We believe that the patient in Guinea has contracted Katayama fever caused by Schistosoma mansoni. Disease is very common in Guinea, infecting almost 1 in 4 people. Commonly causes fever and pulmonary symptoms. The severe case in a non-native person, the characteristic ova on stool examination, and the lack of efficacy of praziquantel during the initial phase of the disease are also typical. Thank you for this great case. All the best, Michelle and Alexander from the First Vienna Parasitology Passion Club. Back to you, Daniel.
All right, I'm going to do a couple here. So Ramon writes, acute schistosomiasis, Katayama fever, probably S. mansoni. So Ramon, Ibiza.
Wow, I'd like to be in Ibiza now.
Me too.
All right, Jay writes, dear trypanosomes, we get to toss our hats in the ring for 2 parasitic infections here. The initial but incorrect diagnosis made at the first hospital. The second correct diagnosis made later. For the first diagnosis, it must be something that can present with fever, cough, bilateral infiltrates, chest x-ray, eggs and stool. It's also something treated with medication that can lead to nausea and vomiting. I suspect the clinicians at the first hospital mistakenly thought this was Loeffler syndrome due to Ascaris lumbricoides. Treatment for ascariasis include albendazole or mebendazole. Both of these medications can lead to nausea and vomiting. I suspect the eggs found on stool exam were asymptomatic infection, very common in Guinea, rather than the cause of recurrent disease. Laffer syndrome occurs in infection before eggs appear in the GI tract, so the diagnosis doesn't really fit our clinical presentation. At the second hospital, they took a different approach. I suspect their diagnosis was Katayama fever due to schistosoma mansoni. The swimming hole was a good clue. She may have been treated with corticosteroids and praziquantel. She got better within 24 hours or so. I first discovered TWiP about 2 years ago. I wrote in my first guest a little over a year ago. I had the honor of hearing Dixon read one of my letters last year. I will miss him on this podcast. My heart goes out to you for this loss, Jay.
Christina.
Justin writes, "Hello, dear host. This case was a challenge and I'm still not sure exactly what the patient was suffering from. My main thoughts are strongyloidiasis and schistosomiasis. Both would have respiratory difficulty and abdominal pain during initial infection. Daniel mentioned she may have gone swimming in local water, which makes me think schistosoma mansoni would be more likely, but strongyloides fouleborni may have been transmitted while walking barefoot on the beach or in a local garden. Both are endemic to Guinea and can cause gastrointestinal disturbance. My final guess will be schistosoma mansoni. I look forward to hearing how to tell these two apart. Thanks for a great show, as always, Justin."
Michelle.
All right, well, I'll go ahead and do a couple. The first one is James writes, inhaled fungal infection, aspergillosis maybe. James from Ridgefield, Washington. Oh, I'm going to mess his name up. Frithoff writes, "Dear professors, greetings from
Osnabrück.
Osnabrück, thank you. Greetings from Osnabrück, the city of peace in northern Germany. I was saddened to hear about the passing of Dixon Despommiers, who co-founded your podcast and played a pivotal role in captivating a broader audience, including me, with the fascinating world of parasitic diseases. Please accept my heartfelt condolences." Regarding the case of the 26-year-old volunteer returning from West Africa, my initial differentials would include malaria, pneumonia, both of which can be effectively treated with Augmentin and Coartem. I would recommend a diagnostic blood smear and thick blood film to help confirm or rule out malaria. The positive stool parasite screen suggests treatment with either praziquantel for schistosomiasis or albendazole for most other parasitic infections, both of which can sometimes cause gastrointestinal side effects such as vomiting. Ceftriaxone was likely administered to cover the possibility of typhoid fever. Ultimately, the final hospital correctly diagnosed the patient with strongyloides stercocaris infection, which responds well to ivermectin. This parasite's fascinating lifestyle involving both pulmonary and gastrointestinal phases perfectly explains the patient's respiratory and digestive symptoms. Given that strongyloides primarily excretes larvae rather than eggs, it can easily be missed during routine stool microscopy. Thank you for sharing such an interesting case.
Daniel.
Ben writes, "Hello all. Again, my condolences about Dr. Despommiers. In his memory, I must mildly chastise you for using Fahrenheit in the show notes. My guess for the parasite is ascariasis. The presence in the lungs is the strongest hint. As for what happened with the two drugs in the vomiting, I guess albendazole or mebendazole caused vomiting. The second drug was ivermectin. The other possibility is that parental was used due to possible pregnancy. It is a paralytic and may be slow to work. Though in this case, the vomiting would have been from ascariasis, not the drug. Thank you. Ben in Liverpool, returning champion."
Jason writes, in TWiP 253's case of the ailing Georgian in Guinea, the patient sounds as if they were initially misdiagnosed with infection with Ascaris lumbricoides and later correctly diagnosed with infection with schistosoma mansoni. The patient's clinical symptomatology, eosinophilia, lung infiltrates, and environmental exposure fits with acute stage schistosomiasis, also known as Katayama fever. The eggs discovered in the ova and parasite stool test may have been incorrectly identified as those shed by A. lumbricoides nematodes. On microscopy, unfertilized or infertile eggs of A. lumbricoides bear resemblance to the eggs of S. mansoni, minus the pathonomic lateral spine. Another confounding variable in the case includes the symptomatic resemblance of Katayama fever to the early migratory phase of ascariasis, also known as Loeffler's syndrome. Patients treated with albendazole for ascariasis are occasionally prone to vomiting, as this patient experienced. If schistosomiasis was indeed the final diagnosis, then a brief regimen of praziquantel should have sufficed to clear out any adult-stage trematodes lurking within the intestinal mesenteric vessels. Jason is a returning champion, still awaiting autographed text. We'll get there. We'll get there. Christina, you're next.
Eyal writes, Dear Vincent and the sages of the microscopic eukaryotes, greetings from Sydney, Australia, where the weather is just the opposite of the northern hemisphere. I'm saddened to hear about Dixon's passing. He was a great human being and, from what I could tell, a great friend. My sincere condolences for your loss. As for the case of the 26-year-old female volunteer with no past medical history, this has me completely stumped. Please excuse my guess, as it is probably so far off the mark as to be ridiculous. I didn't know how to approach this. I've looked at different parasitic diseases in Guinea, but couldn't narrow it down to a diagnosis. There were just too many. I've tried looking at the treatments for each one, but couldn't find a pattern. I've looked at infections with respiratory and intestinal symptoms and then found some interesting correlations. So here is my guess. Based on the respiratory symptoms, bilateral chest infiltrates and some eggs in the stool, the first hospital diagnosed lung fluke, Paragonimus species, and treated her with triclabendazole, 2 doses of 10 mg per kg orally, 12 hours apart. Unfortunately, the lab missed a small spike in the egg, and the lady was infected with Schistosoma mannsoni. At the second hospital, they decided to try praziquantel, which, to my understanding, is the recommended treatment. Luckily, a single dose is sufficient treatment for Schistosoma mannsoni. I wouldn't venture to comment on what went wrong with the management of the case. But on a funny side, if you paste the case notes into ChatGPT, it comes back with a diagnosis of lung fluke. So maybe the doctors in Hospital 1 should place less trust in it. Please take this as a tongue-in-cheek. As always, my gratitude for the knowledge you all share. Regards, Eyal.
Michelle.
Anna writes, hello. As always, your podcasts are equal parts entertaining and educational, with a smidgen of ick tossed in, of course. I love infection prevention with my whole heart, but there are certain facts I choose to disremember, especially when it comes to how many parasites we have living in and on our corporeal forms. I have recently pivoted from 10 years as an ICU RN, so I am just starting out my infection control prevention career. But when I read the case study, Ascaris immediately came to mind. Also because I had just reviewed it in my CBIC exam, sitting for it on 3-1. Wish me luck. My guess would be infestation by Ascaris lumbricoides, both by symptomatology, available diagnostics, and patient location in Guinea. Lumbricoides being the most common roundworm to infect humans in Guinea, suffering under poverty and poor infrastructure for sanitation systems. Treatment with antibiotics and antimalarials were ineffective, but my guess is a single dose of an ascaroidicide like albendazole or ivermectin at the second hospital cleared up her infection. A correct evidence-based use for ivermectin, I might note. Though I do have a Pavlovian surge of fury when I read the word ivermectin these days. Anyway, me too. Anyway, thank you for this interesting consult. I look forward to your next interdisciplinary collaboration. Anna Schroeder, RN, BSN, and soon to be CIC.
That's a great way to put it. I get mad when I read ivermectin now, which is too bad.
Yeah, why do I do that too? Yeah, like it comes up and like, even though it's appropriate, I'm just like, oh, ivermectin. Oh.
Yeah.
When I go to Panama and I use it to treat scabies, I'm like, oh, ivermectin.
All right. So, Daniel, what's next?
Well, I guess now I know the answer. Michelle knows the answer, but Christina, what's going on? What is the diagnosis and what did they do wrong? And what did they do right, maybe?
Well, I'm not 100% sure. So I did actually think a lot about that case. I did find it a bit confusing. And I kind of, my thinking went maybe down the line that Jay went, because I thought the first when she had some eggs in her, some kind of eggs. I mean, I'm not sure if that description even matches an egg. It could be anything really. But I thought reading the rest of it, I thought the eggs are probably not anything to do with what I think she might have. Does that make sense? And it may have just been, I don't know, not a red herring, but an infection that was maybe not actually causing her to be quite ill. And I was thinking that some people also mentioned Loeffler syndrome, but I think she was really too unwell for that as well, I thought. But I don't know. I'm a bit on shaky ground because obviously I'm not a clinician, but from my reading, I thought she was more ill than I would assume from Loeffler, from ascariasis. And I kind of thought about schistosomiasis as well. So the description fits quite well with acute schistosomiasis. And that's why I thought that the eggs before that were maybe a red herring, because I don't know how soon after infection eggs are produced, because acute schistosomiasis is really during that migratory initial phase of the infection. So I suppose if we come towards the end of that stage, maybe some eggs will be produced because there's some adults there already. So that's why the eggs confused me really. But I think possibly she has Katayama fever, and I'm not sure what went wrong. I don't know, maybe an overworked doctor. I don't know.
So if you were thinking Katayama fever, how would you treat it?
How would I treat it? I don't know. I think praziquantel might be effective against adult worms, but not against the migrating schistosomules. So I'm not sure what she was treated with, and I'm not actually sure if I'm right. So I feel like I'm on quite shaky feet with my guesses. So I'm glad we've got some doctors here to put me right.
All right, Vincent, what about you?
So I don't know what happened with the first hospital. I see some of these listeners, they knew what parasite they thought she had, and I couldn't get that. But the symptoms, the lung X-ray, right, the diffuse involvement, the cough, the GI symptoms, Daniel mentioning swimming, and Guinea, it's all consistent with schistosoma mansoni, which when there are lung issues, that's Katayama fever. So I could just get the final thing, which praziquantel would treat, I guess. That's probably what they gave her.
Dr. Labrunda, do you want to bring it all together for us?
Sure, I'd be happy to. So
I hope we're not going to feel too embarrassed.
No, you guys did great. So in the first hospital, they actually did get the correct diagnosis. She had schistosoma mansoni, and that was the egg that they identified in the stool. Wow. They gave her praziquantel, and she vomited it. So they gave her some time to let her stomach calm down, gave her another dose and let her go home thinking that would take care of it. But they had forgotten a really important treatment in this illness, and that's steroids. You want to give steroids before you give the praziquantel, bring down the inflammation. Normally, you would give the steroids until the person had been symptom-free for roughly 48 hours, and then give the dose of the praziquantel. And what they did at the second hospital was to start the steroids. And within 24 hours, she felt much, much better. Her symptoms were gone. She was afebrile and was able to go home.
Wow. I had no idea.
So I was trying to figure out the life cycle in the eggs, Michelle. So, because you think about Katayama fever, right? So you get the acute schistosomiasis, you swim, you got the cercaria, it's on your skin, you get out of the water, and then it penetrates as your skin dries. And then you get the migrating phase through the lungs, so acute schistosomiasis. So were the eggs, was that from a prior infection? What was sort of the story? What were those eggs in the stool, and how are they picking them up?
I don't know a lot about the details of the testing that they were doing, or the details of how they did the testing. It just was reported that she had schistosoma in the stool. suspect that she had a long period of exposure to contaminated water. She didn't go, it wasn't actually just swimming. She did have a brief trip to a swimming hole, but she washed her clothes in local water without thinking about it. She actually was very careful with the filtered water, but for months she had been washing clothes. Her neighbors were kind enough to bring some water for her, but it was contaminated water that she had been using for 6 months or more. So there was probably a long-term exposure. So she maybe had parasites in her system for a long period of time, and just something happened, the parasite load went up, or she was no longer able to manage as well.
It's a tricky diagnosis because usually, right, like going through the life cycle is early on, right? You're not going to get eggs necessarily early on. You can do these antigen tests, the CCA with this circulating antigen, but the sensitivity isn't even great there. So a lot of times you have to treat with steroids, and then later on you'll get your stool diagnosis. So not surprising that an area even where they probably see a lot of this, they kind of didn't jump in with the steroids right away.
Wow.
So she didn't have a rash. I kind of realized that now. So that would probably something that you might have if you had Katayama fever. I'm not sure.
Yeah, a little bit prior. Now you often get more of a rash with the like the avian, right?
Right. Yeah, that's right. Actually, you can get it in Loch Lomond here, and one of my friends did have
duck itch.
Duck itch. Yeah.
Wow.
So I'm just not entirely sure. I just don't quite understand her symptoms, because the description of the symptoms do sound like acute schistosomiasis rather than chronic schistosomiasis.
So, I guess my suspicion is she may have, I don't know what the eggs were. They could have been Asker's eggs. She could have had a lighter prior infection. Then she really gets a heavy exposure, which makes it worse, right? Because now you've got a sensitization to it. Yeah. So it's like a little prior, then you get a more significant exposure. Now you get a heavy load of the Cercaria. You end up with that significant, pulmonary symptoms, the fluffy infiltrates, the eosinophilia, and then you treat her with praziquantel, and it makes it worse because now you've killed some of those original ones. And that's why that would make sense to me if the prior smoldering, smaller infection, now this serious one. And then if you could get the end, but then I think the thing you also have to remember is treatment now will not necessarily kill the migrating phase. You're going to have to remember in 8 to 12 weeks to treat again with another dose of praziquantel.
She got that.
So that's key, because if you don't, right, then later on you can have sequelae because you didn't treat all those. You missed a lot because they're in that migratory phase. So upfront, steroids for a couple of days, pretty high doses, milligram per kilogram. Then you're going to treat initially with praziquantel, and then another dose of praziquantel. I would say 12 weeks later, I
just want to say to Anna, who sat for her CBIC exam, I hope you did well, because you got the diagnosis wrong.
Well, I got the diagnosis wrong, but I suppose I don't have to sit an exam. Well, somewhat wrong. Right.
No, I feel like everyone did well. I mean, Christina, I think you got it. And then a lot of our emailers got it well. So,
I think I've learned a lot because, I wasn't really I suppose I never thought it through, but I just thought Katayama fever, you get that once and then you're done. And every subsequent infection, you're going to just not really. So I hadn't really ever thought that through. So I was quite glad I've been able to think that through now and can take that away.
All right, let's give away a book to someone who wrote more than one sentence. We give her a random number between 1 and 8. We got number 3. Number 3 is Kimona. There you go, Kimona. You've been wanting a book.
Finally got a book. She's actually going to be down in Panama next week at our CME. So
you can take that with you if you have enough space in your luggage. No.
I have to carry it all the way there.
No, we will mail it. She's in Vermont, so no problem. So, Kimona, just send your address to TWiP at microbe.tv with TWiP 255 book winner in the subject line, and we will get you a book out within some time. Hopefully soon. We have some triple signed copies still left. Okay, Daniel. Well, wait, before we do that, Michelle, tell us a little bit about your history, where you came from.
Well, I have a somewhat unusual background for most physicians. So I actually, when I was younger and starting college, I'd planned to become a microbiologist. Then I had the opportunity to go to Mexico, and it turned out that I was going to go to medical school there. So I looked at all the different education programs, and it just made more sense to go into medicine. Had some great programs where I was. So I went to medical school in Mexico after studying Spanish for a year. So my classes were all in Spanish. It was kind of trial by fire, but a great way to learn a language, great way to learn a culture. And it also made me very interested in global health. I learned a lot about regional differences within Mexico, the social determinants of health, before we called it social determinants of health, and how a lot of that played into health and education. Once I left Mexico, I actually did a fifth pathway program in New York City. That was at a hospital that later closed. The fifth pathway program closed. I did my residency at Cabrini Medical Center in New York City, which also closed. So I have this trail of closed programs behind me. Then a few years went by and I ended up in Florida. So I have been a hospitalist in Melbourne, Florida for many years. And as I was doing that, I continued to engage in global health. I would go on trips to quite a few trips to Peru. I would help in Uganda and some other projects within Kenya. And I really was attracted more and more to that. I found that it made me a better clinician, a better hospitalist, but also my hospitalist and clinical work made me better at the global health work as well. And so they really complemented each other. But I wanted to move more into the global health world. I went back to school, got a master's of public health in humanitarian assistance and disaster management. And at the same time, my husband did a fellowship in global health in California. So as we were doing this, we ended up flying all over the place for different projects and things. I probably have the world's record for the most number of final exams taken at 36,000 feet, because I would take them on internet while I was on airplanes. I took a final exam in Zanzibar because we were traveling there. So I have, this remote program where I just would take it with me wherever we would go. And I didn't let it stop me. I just, would do it. I wrote term papers in Kenya. So the studies I was doing really complemented the work I was doing as well. So went through that and did that for a number of years, where I was alternating hospitalist work along with the global health work. And then COVID came. I initially went to New York, helped with some of the COVID response there, and then ended up applying for a position with the UN's World Food Program. And I was supposed to be a 3-month position with the World Food Program. And I became a medical officer. So I covered all of Latin America, the Caribbean, and I helped them with their COVID control for all of their offices throughout Latin America and the Caribbean. So headquarters was in Panama City. I spent a lot of time in Panama City. I also traveled quite a bit throughout Latin America, doing everything you can think of with COVID. And I have to say the TWiP podcast saved me. I didn't have time to read all the articles, so I really became a dedicated follower at that point, and all the information was really instrumental in coming up with the policies and procedures that we would follow that kept all of these employees safe, because we kept delivering food during COVID, and we had kept operations going, and we wanted everybody to be as safe as possible while following all the rules and regulations, of course. So that was really an exciting time, scary time as well, but very exciting, and I was grateful to have the opportunity to help with that. And of course, those 3 months turned into 3 years, and my role within the organization evolved over time. But as COVID settled down, I transitioned into a different job, and that was Chief of Medical Standards with the Peace Corps. I did that for about a year and a half, and that was also a very interesting job, working with volunteers all over the world, and also helping to set up the pre-service policies and procedures. So those are the people that want to be volunteers, and we want to make sure that we can take care of them wherever they go. So they will give us their list of medical problems and say, I want to go to Swaziland or Botswana or wherever they want to go. And we make sure that they can be taken care of there. And it's amazing the things that we're able to do. We have networks of physicians all over the world, and we can actually take care of a lot of things. Not everything, but we can take care of a lot of things just by having that infrastructure set up and those connections to the other doctors. So now I'm in another transition again. I'm starting to practice again in my local community, and I'm actually just starting back with an organization where I worked for a long time, and we're starting a new academic organization. So we're going to have our first local GME and opening an internal medicine residency program here, hopefully within the next year or so. So that's my next big project. And of course, we'll continue to work as much as I can within the global health community and try to get all of my future residents interested in helping the global community as well.
Well, you're a doctor without borders, aren't you?
Exactly.
How do you know Daniel?
We met in Thailand, actually. We were doing a global health course in Thailand, and we met there.
Yeah. So, Daniel, how did you find out about this case?
So we were in touch, and I got this case from Michelle. So.
Oh, okay.
Yeah, I was just in Thailand last week, Michelle. So old stomping grounds. I was
Nice.
doing some talks, and actually one of the guys was from Mahadal, where we spent some time.
Oh, nice. Beautiful country.
Cool.
You were also in Malaysia, weren't you?
I was, and
you bumped into one of my students, former students, now teachers. Such a small world.
Actually, that was fun. Yeah, I did a talk with one of your former students.
Yeah, he sent me a photo of the two of you, looking really happy.
It's a small world out there.
Small world.
Well, Daniel, speaking of Malaysia, is that where you got our next case?
That is where I got our next case. So let's go. Our next case. This is actually fun. So here I am in the northern part of Borneo, and I'm having dinner with the chair of this session that I spoke at, and his wife. And so the wife tells me this story. So she sees this man, and she's treating him with a certain drug called eculizumab. And this is a recombinant humanized monoclonal antibody that targets complement protein. He's got an issue with complement. This serves as a terminal complement inhibitor. So she's treating him for this, right? She's not an infectious disease doctor herself. But he comes in with a complaint. His left arm has become swollen. So she remembers, what she's learned about it in medical school. So she says to her husband, who was actually the infectious disease doctor, look, this left arm swollen. Do you think it could be this parasitic disease that we learned about in school? And he says, no, we don't have that here. That's not something to be concerned about. But, she doesn't listen to her husband because, And so she actually admits this gentleman to the hospital, schedules to do these nightly blood tests. They're going to look at the blood smears at night, and they come back negative. She's still not dissuaded. So she goes ahead and she does this rapid immunochromatographic dipstick test, like a rapid antigen test, and it actually comes back positive. So this really gets her kind of, reassures her that this might actually be that diagnosis that my husband doesn't think is to be considered. So she gets a little more history, finds out that people in the village outside of the city where this gentleman is from, several others have issues with limb swelling. So they actually go out, they do a bunch of testing in this community, a bunch of antigen testing, and they find that the people with the limb swelling also have these positive antigen tests. So they go ahead, we talk about like the different treatment options, and she lets me know that she doesn't have access to the medication that she would want to use. So instead, they put this gentleman on an antibacterial agent for 4 weeks. And the arm actually gets better.
Oh, I got that part.
So I'm going to tell you, though, this is not Wucheria Bancroft.
Yeah, but I know why they used an antibiotic.
So you have the idea of what antibiotic they might have used and why.
Yeah.
Yeah.
All right.
I think I might know the parasite too.
Okay.
Does he have HIV?
He does not have HIV. And I think this is enough. I think people will be able to get it from this.
Are you telling me not to ask you any more questions?
You can ask more. Go ahead and ask more. I don't know much more. This is
okay. That's it. That's fine. That's absolutely. So he lives in this village. Is a rural village with thatched huts and all that stuff, right?
Yeah, it's rural. It's outside the big city. He comes to the city for his care for this, whatever disease it is that he's being treated with this.
Is he walking around barefoot most of the time?
No, he's not barefoot. But there's plenty of those flying things.
Yeah, I was going to say, did he get bitten by something?
Yeah, I mean, they don't have screens. They don't sleep under bed.
Okay, thank you. That's great.
Yeah.
This is not Wuchereria. All right, that's TWiP 255. You can find the show notes at microbe.tv/TWiP. Now, you want to send in a case guess. I'm not going to figure out the timing. There's just no way I can do that. Just send in a guess. This is going to be released, I don't know, in probably 2 weeks. And so get your guesses in 2 weeks after it's released. And you can send your guess to TWiP at microbe.tv with TWiP 255 clinical case in the subject matter so we can sort it out. Okay? And as I said earlier, if you like these kinds of programs, we'd like to have your support, microbe.tv/contribute. Our guest today, physician Michelle Labrunda, Physician Without Borders. Thank you for joining us, Michelle.
Thank you.
Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Oh, thank you. Everyone be safe.
Christina Naula is at the University of Glasgow. Thank you, Christina.
Well, thank you. It's been really fun. And Michelle, thank you for an interesting case. I've learned a lot.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. So, Michelle, I'm going to have you sign out. All you have to do is say another TWiP is parasitic, okay? When I finish my part, okay?
Yes.
You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.